who constantly encouraged us, believe in us. Welcome you, ma'am. And energetic welcome to all the HODs, faculties who takes constant effort for the development and learning of the students. Welcome you all faculties. I offer a glad welcome to our students, participants who are set to make this session a remarkable one. With all enthusiasm, I welcome you all once again for this wonderful session. Thank you. Now, I take this opportunity to introduce the speaker. Our speaker, Mr. Samuel Nyanamani, theatre practitioner, Broomfield Hospital, United Kingdom. He has completed BSc Nursing in 2002, MSc Psychology in 2005, Diploma in Perioperative Skill in 2006, MBA Hospital Management in 2012. He had worked as cardiac theatre practitioner, Apollo Hospital, Colombo, from 2003 to 2004. Next, he had worked as generic pediatric theatre practitioner, Royal London Hospital, from 2005 to 2014. Currently, he is working as theatre lead practitioner, Broomfield Hospital, United Kingdom, from 2014 to till date. Thank you for your presence, sir. We are eagerly awaiting for your plenary session. Now, I invite our Honorable Principal Ma'am, Dr. Mallika Kannan, to deliver a keynote address about today's webinar.
So with this heavy introduction, I take this opportunity as Principal Indrani College of Nursing to welcome Mr. Samuel Nyanamani, theatre practitioner, Broomfield Hospital, United Kingdom. He's our, what to say, I can say he's one of our home person for Indrani College of Nursing. He's having a lot of interest towards Indian, especially our Tamil population and the students. So he has already delivered a lecture to us in person when he was in vacation here. And he wanted to give credit to the Tamil students especially. So with this good fee, again he has volunteered to talk about cardiac surgeries. So when you take about cardiac surgeries, it is vast actually. It's very vast. So a lot of valve replacements, graft surgeries, starting from angioplasty. There are so many adult surgeries, and pediatrics it is endless as they are born with the malformations. So with this short notes, I would like to open today's topic Today's topic for presentation, which is cardiac surgeries deep dive. So as the name says, cardiac surgeries, we will see a variety of surgeries through Mr. Samuel. And there is no doubt cardiology is the ocean only. So deep dive is the apt heading given to this topic. So I think at the end of this presentation, all the participants will achieve a deep knowledge in the cardiac surgeries. So with this short notes, once again, I wholeheartedly welcome Mr. Samuel for this presentation. And I also wholeheartedly thank our faculty, Professor Ganeshan, his close friend of Mr. Samuel, for taking all efforts in arranging Mr. Samuel for this presentation. I welcome Mr. Samuel for the presentation.
Thank you very much, ma'am. First, thanks to Ganesh and ma'am Mallika Kannan for having me again. And as ma'am said, cardiothoracic is a very vast topic, and trying to cover cardiothoracic in hour and a half is quite impossible. So, second thing is, and I don't know how many people have worked in theaters as well. So there's no point in me going into too extensive of cardiothoracic surgery because it won't make sense at all. So I'll try to keep it very interesting by engaging a lot of pictures and other things. All can everyone hear me clearly? Is first thing.
Yes, very clear.
Okay, so I will just go straight into presentation. I've got some pictures to show. I've got some a PowerPoint to share with you all. Yeah. So I'm going to start. Can you all see my screen?
Yes.
Oh, perfect. Thank you. Okay, can you see the screen now?
Yeah.
So today we're going to talk about cardiac surgery and deep dive. So first thing is just to get a bit of basic knowledge about theaters. So I just thought, let's start with a little bit of theaters, and then also what are the current trends in theaters. Then go see a bit of cardiothoracic surgery. So the first thing is just to look into the overview of the content. So what we're going to talk today is first is the introduction to surgery, then talk a little bit of open, keyhole,
Sam.
robotic, and pinhole surgery.
Sam,
சொல்லுங்க ma'am.
it's not this too big. Screen is too big, so half of the contents are hidden on the left side.
Half of the content is hidden.
Participants can be
இப்போ ஓகே மேம்.
இப்போ இப்படிதான் இருக்கு, அப்படிதான் இருக்கு.
Now?
You can minimize. No, now also it is the same.
I mean, I can see in, I don't know what, so you can't see, can you see the content, or is it been hidden?
only few lines is visible, sir. At the end only we can see it.
Okay.
You minimize it.
So now I don't know who is expert in this. This is my first time I'm doing a Zoom thing. So what I've done is I've done the PowerPoint and I'm running it as a background screen.
Okay.
So I'm sharing it as well. So
No, you just go to slide share only.
Slide share, yeah.
And go to the full view. That's all.
Is it better now, or is still you can't
Yes.
see?
That's good.
No, it's clear now. It's clear.
இப்ப தெரியுதா ma'am?
Yes, நல்லா தெரியுது. But slide
Okay,
share.
thanks.
Slideshow. Yeah.
Yes, yes, slideshow. Yes.
Can you see it now?
Yes, yes, very clear.
Oh, perfect. Thank you. So the content for today is introduction to surgery. Then talk a little bit of open surgeries, keyhole surgeries, robotic, and pinhole. And then go to cardiac surgery. Then talk types of cardiac surgeries. Then talk about CABG, which is coronary artery bypass grafting. What is on-pump versus off-pump cases. Talk a little bit of heart-lung machine. And then pediatric cardiac surgery, then talk about the future of cardiac surgery, then have a little slide about cardiac theater team and cardiac theater and essential in theaters, and last is, I mean, if you got any questions for me, you can ask me. So just going back, if you could see the screen clearly, so that is a pretty much history of surgery. The top picture has been taken from MIOT, sorry, the triple M, நம்ம சென்னையில இருக்க triple Mல எடுத்தது, and it shows like it's a bit of like biblical description. So there you can see God taking the first rib from Adam. So, and then if you refer it to the Bible, I think this is the first time we can hear about surgery where God says, I'm putting Adam into a deep sleep and taking his rib off to make the first female. So I just thought that will be a good introduction to a history where that is the first time in some textbook they're talking about a surgery. So if you look into any history, the history goes behind 2000 BC, where you got a lot of scripts about surgery and the various form of treatments. whether it can be in India or it can be in Egypt or it can be in Western society. But then if you collect all the treatment, it will only come under 4 or 5 categories. First is trepanation, which is basically making a hole in the body cavity. Second is setting up bones. Third is anesthesia, and last one is bloodletting. So generally, if you go back and look in the history, most of the times people believe that the disease are all been caused by bad blood. So any kind of treatment in any part of the world was pretty much letting the bad blood out of the system, or in other terms, just basically opening a cavity and letting a bit of blood out. And then they thought by doing that, the bad blood comes out, then the body gets enough time to produce clean blood, and then the person becomes normal. So the first word is like trepanation, is like making a hole in the body cavity. So I just want to share something here. So if you work in emergency theaters, and if you have road traffic accident, if you see those patients, they come into A&E absolutely confused and loss of consciousness. This is basically they have an increased cranial pressure, the brain compressing the cranium. So what we call is something called a craniotomy, emergency craniotomy, and release of subdural hematoma. So it's basically they do a craniotomy, open the part of cranium, release the hematoma. Once they release the hematoma, then they put the patch back, put the cranium back. The person becomes absolutely normal. So a person who comes into operating theater full of confusion and loss of consciousness, if you ask him what happened, he will say, oh, I was in motorbike. Next minute, all I know was I crashed and I lost my consciousness. But then in the post-operative, he will gain his all consciousness back. He will gain his memory back. So a trepanation is a similar therapy. And nowadays it's called either craniotomy, or if you're talking about increase in abdomen pressures, we do laparotomy. So otomy means opening, and opening of the body cavity and releasing of the diseased blood helps the patient. Same thing again, setting of bones. Setting of bones never changed. If you align a bone in the normal anatomy, the bone gets healed. So that is how, and there's a lot of theories behind it. So in India, they would have done it in a different way. In Egypt, they would have done it in a different way. In Western countries, they would have done it in a different way. But the fundamentals was same. So 2000 years back, the same practice of what we call medicine and surgery in India would have been the same as somewhere in Egypt or somewhere in China. The concepts are same thing. Again, anesthesia. So if someone got immense pain, how do we elevate this pain? How do we bring this pain down? So in India, we would have had herbal therapies. In China, they would have a different kind of therapy. So, and the last one is bloodletting. Again, it's the same concept where you make opening in the body, skin or anything, drain the dirty blood off, and give a body a chance of making clean blood. So these are the 4 sets of treatment which was done historically by different cultures and different parts of the world. Again, going into surgical terminology, so I know exactly, you would have all done your medical and surgical. The suffix word is the same thing. So it will tell you what exactly is going to happen. So if you look into my screen, it says ectomy. Ectomy means removal of a particular body part. So imagine if someone got an inflamed appendix, or if someone got an inflamed bowel or an obstructed bowel, so we call that appendicectomy. Or if you want to do a bit of bowel resection, you got a laparotomy, and you do a colectomy. If the colon is the one which is affected, we cut the colon off, put it in the bin, and we call it as a colectomy, and then we do an end-to-end anastomosis. So if you see the suffix of it, it tells you what exactly is a surgery we're going to do. Then you can put what you want to do in front of it. So imagine if I want to do a laparotomy, that means I'm opening the abdomen cavity. So lapro means abdomen. Same way, if I want to do a craniotomy, then it's opening of the cranium. Then if I want to do a gastrotomy, that means it's opening of an stomach. If I want to do an esophagectomy, means I'm taking a portion of the esophagus. Or osteotomy, though by getting the first word and getting the last word, you pretty much understand what kind of surgery we're going to do. So imagine if I'm working in theaters and I'm working as a scrub nurse, I know exactly what will happen today in my list. And being working in theaters for so long time, you know exactly what set of instruments, what set of how to prepare the theater. So if it is a laparotomy, it is a different set of instruments and the different way we position the patient. If it's a craniotomy, it's totally different set of instruments. So looking into the procedure itself, we can tell exactly what kind of things one. Just want to add something here like nephropexy, which is like surgical fixation of the kidneys, or nephrectomy means removal of the diseased kidney. If you want to do any kidney procedure, we have to put the position on patient on a lateral position. So there are different kind of positions in theaters. Like you can have a patient on prone, supine, lithotomy, lateral. If you're doing a craniotomy, then the patient will be in supine with his head fixed in a craniotome so that the head doesn't move. So being a theater practitioner, which I've done for nearly 15 years, by looking into the patient list, I know exactly how to prepare for a list. So I just thought I'll share this slide purely because we as students, we get too confused with a lot of surgical procedures. So that basically, if you know the suffix of it, then your first words will tell you what exactly is the procedure of the patient. Again, just going back into it. See, I started 15 years back. Now it's going to be 18 years back in theaters. Theaters, especially operating theaters, and then the field of surgery is growing so much that you even cannot catch up. So if I take a 10 days of leave, I'll come back into theaters. There is something new. Either it might be a new implant, it might be a new surgical technique, it might be a new machines and other things all. So the evolution of the surgery is going so fast that even people, if you missed a couple of days, you won't even able to catch up. You come into theater, there's something new, especially. So if you look into the trend of the surgery is like earlier time, we used to open. It is called open surgeries. And then we went into a trend called keyhole surgeries. That means making little holes in the body cavity. Then we do the procedure. Then now the trend is called pinhole surgery, which is basically like a little pin. How imagine, we can example give a safety pin, or even a venflon. When we put a venflon, that amount of surgical incision, we can do a whole procedure. Just want to give you an example here. So earlier times we used to do laparotomy, which is called an open surgery, which means you open the abdomen cavity, then you expose the abdomen cavity, then you do what you want. If you want to take the appendix, you take the appendix off. If you have an obstructed bowel, we go in, we find the diseased bowel, we clamp the diseased bowel, cut the diseased bowel, do an end-to-end anastomosis. That is an open procedure. The problem with open procedure, as the slide says, you have longer stay in the hospital, a bigger wound, pain is too much, chances of getting infection. Whereas a keyhole surgery, if you see the advantage of it, it is very little holes. So you do, you add little holes in your body cavity. Then how do you do it? Is you pass a camera through your body. So obviously, when you pass a camera through a body cavity, the body is fully dark inside. So we need a light. So the camera carries a little bit of light. So imagine putting your iPhone or your camera phone through a dark space. So you're putting a camera, then you flick your light on, then the whole area becomes illuminated. The same way, we put a scope through a body, we pass a light through it, the whole body becomes illuminated. The body, you can see what you want. Then you put certain ports. So I just got a port here. So I thought I'll bring in a port. So this is a classic example of a port. So I don't know how many people have worked in theaters in this crowd. but this is called a laparoscopic port. And you can see it has a trocar, it has an operator. You can open it like that. So what you do is you go make a small incision in your body. Then, so imagine that's your body cavity. Then you put this port through the body cavity. Then you come on the other side of the abdomen cavity. Then what you do, then you can see it here. I'll take this operator off. Then this port sits there. Then with a little injection, there's a little syringe here. I blow the balloon up. So you can see the balloon is gone up. Then this forms a wedge. So the port won't move from this body. Then what you do is then you pass your instruments through this instrument, through the port, and do your surgery. So here I've got a laparoscopic scissor, a little laparoscopy. I don't know whether you can see that there clearly. It's a scissor. So you can see it's like a normal scissors which we use to dissect the body part. So, and then this is called a laparoscopic scissor. It has a long shaft. It has a little electrode here. If you can see it here, a little electrode there, where we connect the diathermy. Diathermy is something to burn the body parts if there is a bleed or something. So you use a scissor to go and dissect it. So earlier times we open a body cavity, depends on what kind of surgery we are doing. We open it to that big or that big and do the procedure. But nowadays you don't have to do that. You take a port, you put the port in, then you can see this little inlet here on the port. So what you do is you connect a gas. Then when you connect a gas and put gas into your body's part, your abdomens become too big, then your intestine and other things all starts freeing up. Then you can see what you want to see. Then you can put another port side by, then use another dissector to move away structures and see what structure you want and do your procedure. So this is a trend here. But the problem here is, as you can see, that any technology will have its own disadvantages. So the disadvantage here is a damage to an organ such as bowel or bladder. So because you're working from outside, like eating with a chopstick, in a Chinese hotel, when you eat with a chopstick, your chance of dropping your noodle is more, unless you know how to use your chopstick properly. The same way, any surgeons in the beginning stage will have complications in doing the procedure. There might be a damage to the bowel. When he's trying to go and reach the appendix, he might nick the liver. He might hit the bowel, or so this can cause him a bleeding. So it might be a damage to a major artery. Again, second thing is we use carbon dioxide. Again, why we use carbon dioxide? Because we cannot use oxygen in the cavity, because we'll be using diathermy, which is like a heat energy, and then the whole bowel can catch fire, or there's an incident of fire in the theater. So you can't use oxygen. So use carbon dioxide. Second thing about using carbon dioxide is our body has a natural ability to exhale carbon dioxide. So at the end of the procedure, the excess of the carbon dioxide do get absorbed and being exhaled off. So that is one advantage of using a carbon dioxide. But another advantage is, I don't know if you can understand this picture completely. When you start blowing your abdomen cavity, what is next to the abdomen cavity is your thoracic cavity. And what will happen? All this intestine and the stomach will start pressing on the thoracic cavity. Obviously, when you press on thoracic cavity, it's going to affect your breathing. Then the anesthetist will be struggling to ventilate the patient. So laparoscopic surgery has its own disadvantage. Second thing is the loss of the tactile sensation, because in the past, a surgeon, when he opens a cavity, he will touch and see. He will say, okay, that is diseased, this is healthy. When you're doing from outside without touching the cavities, the surgeon's tactile sense has been lost. So that is, and then again, you can see the last line saying that there is a chances of gas bubbles entering the vein. So there is a more chance of patient getting a PE, a pulmonary embolism, or a VTE, venous thrombus embolism. So we have to be very careful when we do laparoscopic surgery. Yes, it has its own advantage, but there is also disadvantage. Second thing is, again, it depends on on the training of the surgeon. So the more the surgeon is well trained, he can do these things. So again, the surgeon himself knows the benefits. For a young, healthy adult, it is good to do it through laparoscopy. Whereas if you got a very old, deceased person, like if he's in his 80s and come with a chronic bowel obstructions, there's no point in me, the surgeon, doing it under laparoscopy. He might say the patient is too sick, we'd rather open it. So the surgeon will decide what he wants to do. Another new trend is called the pinhole surgery. So I don't know how many people would have heard this term pinhole. Is totally to do with intervention radiology. So earlier times, when we'd want to do any procedures, as I clearly mentioned earlier, we open it, but now we make a little Venflon. So imagine if you're using a Venflon, you put a Venflon in, then you pass a guide wire through the Venflon, then you take the Venflon off, then use a dilating sheets to dilate it, then pass therapeutic cables. So where all we can do it. So earlier times, example is AAAs, which is called abdominal aortic aneurysm. So like in I don't know how we learned about aneurysm. When you learn about aneurysm is as the ages go and people, chronic smokers and chronic drinkers, the elastic nature of your vessel starts given up. So earlier times, an aorta will be of that big, I would say 15 millimeters. In an aneurysm, it might turn into a 30 millimeter aneurysm. That means what? There is one chances at any time this can explode. It can become a ruptured aneurysm. So the patient might die immediately because all your blood volume is lost. Or his whole blood pressures play up because you've got a dilated vessel. The moment the vessels become too dilated, it starts messing up with your blood pressure. So earlier times, if you see an abdomen aortic aneurysm, you have to open a patient, then find out where is an aneurysm, clamp the aneurysm, cut the aneurysm off, chuck it, then do an end-to-end anastomosis. Or if the cavity is so big, you cannot bring the vessels together, you take a graft, you take another pipe and connect it end-to-end. But nowadays, you can do it completely through pinhole surgery. This is called EVAR, which is endovascular aneurysm repair. So from a life-threatening surgery, it becomes into a pinhole surgery where you put a little Venflon through the leg, find a femoral artery, then they put a Venflon, they send then they pass a guide wire. They do it under radiology, means they'll have an X-ray there, and then they find out where the guide wires go and find out where it sits. Then they deploy a stent into the aneurysm and make sure that the aneurysm doesn't get ruptured, and they strengthen the core of the arteries. The same technology is used in angioplasties. So these are called pinhole surgeries, which is much more finer than a keyhole surgeries of laparoscopic. Again, just another new trend is now it's called robotic surgery. So I don't know how many people have seen a robotic surgery, but I just want to tell you, robotic surgery is the same type of a keyhole surgery, which is a laparoscopic surgery. But the only difference is, instead of surgeon standing next to the patient, the surgeon will be working in a console. So if you have children in your home, if you got Xbox or PlayStation, the same technology is here, where you as a controller will be sitting a bit in your sofa, then playing a cricket or a football where you do your body movements. Then in your TV screen, you can see the players moving the hand. It is a similar technology. But what makes robotic surgery more clever than a laparoscopic surgery is, you can see here, it's a greater visualization. Means like in a laparoscopic, we only use 2D, whereas in a robotic, we do 3D camera. So in the scope, at the end of the scope, so your scope will be like this. Imagine that's my syringe. The scope will be like this. In a 2D camera, you'll have only one camera at the end of the scope. Whereas in a 3D, we'll have two cameras. There'll be one camera here, second camera here. A similar technology, how you watch a 3D movie. So a robotic surgery will have a three-dimensional view. That means you can see an organ in a third dimension. Then you know. So imagine if I'm holding the esophagus, I know the circumflex of the esophagus. If I'm holding a stomach, I know where the stomach ends. Whereas in the laparoscopy, you can only see it from the top end. If you move your camera from the bottom, then you lose your top end vision, and then you see from the bottom. Whereas in a 3D, you can have a three-dimensional view. Second thing is enhanced dexterity. Dexterity means, like, you see here, if you're working with the laparoscopic surgeon, you can clearly see he will hold his instrument like this, and human hand has a bit of restriction. He can only go like that, like that. It cannot do much more range of movements. Whereas if you're working in a robotic theater, you can see in the picture, you can see at the bottom, you can see a surgeon is using his two fingers to control the console. And when he moves his finger, the instrument in the cavity moves. Now I've got a robotic instrument here. So you can see, I don't know whether you can see it clearly on my camera, but you can see the tip, and you see the way the tip moves. A human hand cannot do this technology. Look at that here. If you can watch, it turns, and it turns in a 360 degree. Whereas we humans, we cannot do that. So here this is a robotic instrument, and this is a laparoscopic instrument. A laparoscopic instrument is held by a surgeon by his hand, whereas a robotic instrument will be held by a robot. So what we do is we go and dock this instrument in the robot hand. So the robot will hand. I'll show you. So if you see, that is a classic example of a robotic thing. So I don't know whether you can see the top picture where it says patient cart. Can you see the patient cart? It has 4 or 5 hands. And if you see very closely, you can see, sorry, I don't have a pen or anything, or I can't do a marking here, but if you see the hand of the robot, and next picture says sterile adapter engagement verification, it has 4 bobbins. So it is similar to a puppet show. If you've seen a puppet show, how puppets have been handled by the string. So this part of this round bits will sit onto that round bits there. The picture onto your right hand top. So it engaged there. By moving that bobbins, this instrument tip will move. So a surgeon sitting on the patient console, if you see at the bottom, you can see a surgeon sitting in a console watching a movie. So it's a 3D eyepiece he's watching, and he will use his wrist. If I come to the previous picture, you can see him moving his wrist. By moving his wrist, the robot will engage and move this end bit. And also, if you see, the surgeon is sitting well away from the patient. So he's not sitting next to the patient, he's actually sitting away from the, so that part of the machine is called surgeon's console. It's like similar to our PlayStation console. So he will sit in a surgeon's console. You can see him looking through the eyepiece. Then you got the patient cart. So that is the actual robot. You can see it has 1, 2, 3, 4 hands robot, whereas a human has only 2 hands. Whereas here you got 4 hands. That means what? You don't need another person to hold a camera for you. The robot can hold the camera for you. If you see these kind of robotic surgeries, they take like 6 and 7 hours of time. You can't have a man holding a robot, because soon he's going to get tired. His hands become spasm. So the robot will hold a camera for him. The remaining 2 hands will do the procedure, and the surgeon sitting in his little console, seeing it as a 3-dimension, move his finger. By moving his fingers, the robot will move, engage this piece of equipment. This is called the robotic instruments, and we get the procedure done. Here, if you see, so that is a forceps, means it is something very gentle to hold an organ. The similar one there is a tip which is called a scissor. When you can use it to cut it. We have hooks to make hole into it. So that any procedure which you can do it as an open, you can do it through through a robotic surgery, because it has all the instruments which we can load it onto the robotic hand and we can get it done. But what is the disadvantage? Again, when it goes into greater technology, you're going to have, as it clearly says, the advantage of 3D, enhanced dexterity of 360-degree, greater precision, because you're working on a 3D, you know where exactly you're going to be operating. Reduce pain, faster recovery. The disadvantage is very expensive, because these instruments are so expensive. And again, the problem is the instrument has certain life. You can use only an instrument for 10 times. After 10 times, the machine won't recognize this instrument. Second is movement of latency. It means like when a surgeon moves his hand, it takes a couple of extra seconds for the robot to recognize and move the instrument. Again, loss of tactile sense. If you ask an experienced surgeon, very old surgeon, he will say, by touching a piece of human tissue, he can tell you what exactly is the problem. We have worked with very old surgeons who are very clever. By holding a piece of bowel or holding a heart in their hand, they can tell you what exactly is the problem. Whereas if you've got a robot which is holding a piece of thing, you are losing that knowledge on this patient. Again, robotic assisted surgery can cause nerve paralysis. Means like we will be positioning the patient in an extreme position. So imagine if you're doing a robotic prostrate, you have to put the patient on a reverse Trendlen birth. So imagine, so that's supine. A reverse Trendlen means head down for longer time. And these procedures take nearly 6 or 7 hours. So what will happen if you hang a person upside down for 10 hours? Obviously, it's going to mess up with his ventilation, his blood pressures and other things. So that is a problem. Plus, you can have pressure points in your body that can cause a bit of pressure damage to your skin. Again, mechanical failure. You see, robotic surgery, the biggest problem with robotic surgery is you never know when the robot will stop. Then you have to immediately dismantle the robot from the patient. Then you open the procedure and complete it. I have done few robotic cases. In the few robotic cases, I've had one open procedure where we have to dismantle the robot, and because the robot stopped all of a sudden, then we have to open it. So these are the problems with robotic surgery, but otherwise the technology is brilliant. So that's where, okay. So now we are going into the topic, which is cardiac surgery. So just want to check the time as well. So if you look into it, again, the history of surgery, we discussed a little bit of history of surgery, but if you look into cardiac surgery, it doesn't have a massive history where it all started in 19th century. So the first successful open heart surgery on a human body was done in 1953 by a person called John Gibbon. Actually, John Gibbon is the one person who also invented the heart-lung machine. Second thing is the first coronary artery bypass surgery was performed in the United States in 1960 by a team head by Robert H. Kurtz. Another Soviet surgeon has done another CABG in 1964. See, if you look into the history of surgery, it is all started. The advancement started in 17th centuries. But cardiac surgery came a bit later, purely because anything to do with heart, because you cannot open a heart. The moment you open, it's not like your abdomen cavity, where you open an abdomen cavity, you expose. Still, your heart will be pumping the blood, your lungs will be ventilating the body. So the two important things are happening. But when it comes to actual surgery on the heart, you cannot do it without the help of something called bypass machine. So when the surgery start evolution in 1950s after the invention of the heart-lung machine. Before that, they were doing a lot of works around cardiac surgery, but that wasn't being recorded purely because they were like all illegal practice where you open a patient, then you try to do something and the heart patient dies. So if you go into larger medical museums and other things, all you will see people done a lot of works on cadavers, a lot of cardiac surgeries on cadavers. The history says they would have done it on cadavers where they go, they rob the bodies from the graveyards. If you see a lot of histories, it says they go rob the bodies or dead bodies from the cadaver. They killed people. They did a lot of cardiac surgeries, but that was never recorded because the patient never survived. Because the moment you open a heart, it bleeds and the patient dies immediately. So the history got changed after the invention of heart-lung machine, because if you want to work in the heart, you need to bypass the blood. If the blood is still in the heart, you cannot work. Does it make sense among yourself? Many people in India, we have this. My father had a cardiac surgery. Yeah, he had a CABG. We always say that, and it is a right phrase as well. If you ask my father, he'll say he had a open heart surgery. Actually, he didn't have an open heart surgery. They opened his thoracic cavity. They exposed his heart. They worked on the surface of the heart. They never opened the heart. But if you see the way they always talk about, when you talk about open heart surgery, any CABG, actually, in a matter of fact, a CABG should not be called as an open heart surgery because you work on the surface of the heart. Whereas a congenital heart diseases like ASTs, VSTs, and TOF, you can call them as an open heart surgery, or even a valve replacement, which is like a tricuspid valve replacement or an aortic valve replacement, can be called as an open heart because you bypass the blood, then you open the heart, expose which valve you want to take, and you take it off. Am I making sense? But it is absolute normal to call a CABG as an open heart because it's historically called as an open heart. It's just an opening of the sternum and exposing the heart, bypassing the blood. Before going into your medical and surgical, you need to understand certain concepts in cardiac surgery, which are totally different from general surgery. So in cardiac surgery, you have extra equipments and extra pieces of machines and instruments because you have to bypass the blood. So imagine someone going for a craniotomy or a laparotomy. What will happen? The patient goes into theater, has a general anesthesia. By having general anesthesia, what do? You make a patient go deep unconscious, paralyze his muscles so he cannot breathe. He cannot breathe. His lungs will be stopped by a certain drug. Then you intubate a patient, connect the patient to a ventilator. So here the ventilator takes the part of your lungs, open and close your lungs and open and close your thoracic cavity, give you oxygen through the ventilator. Then the surgeon goes open the abdomen or open the cranium, does the procedure, then he close it off. Then what you do? Then you reverse the effect of the drugs. Then slowly the patient starts breathing. Then you take the tube off, send him to the recovery. So this is a course of a normal surgery. Whereas in cardiac surgery, there is something extra added on to it. Because in the cardiac surgery, you're dealing with heart. In other surgeries, you don't deal with heart because the heart will be still working and the heart will be still pumping the blood around the body. And the body will still get its own blood, still get its own oxygen till the metabolism happens. But here, we are touching the heart, the main engine of the body. So we got something called heart-lung machine. So the difference in a cardiac thoracic surgery is here a patient comes into theater, put a tube onto the patient's mouth, anesthetize the patient given a massive dose of painkiller. Then what they do, they open the sternum. It's called sternotomy. They open the sternum and the chest cavity opens. Then you expose the heart. Now you want to work on the engine, but inside the engine you got blood. So I need to divert the blood. But by diverting the blood, what you're doing is you're making sure the blood is still circulated in the whole body through the machine. So still your brain will get the blood, your legs will get the blood, your abdomen will get the blood, your intestine will get the blood, because your nature of surgery is a minimum of 2 hours to a maximum of 12 hours. For the 12 hours, you have to make sure the patient is getting the blood all throughout the body. So here, a heart-lung machine comes. Heart-lung machine, the term itself says it takes over a heart and a lung of a body. So once you anesthetize, once you open the sternum, what you're going to do is now you got the heart which is beating and it's circulating the blood. You're going to put cannulas on the heart. So you put cannula in the heart, then bypass the blood into this machine, a lovely machine, which does the part of a heart and a lungs. So at this part, if you see, if you work in a cardiothoracic theater, the anesthetist will actually switch off the anesthetic machine. He will go to the theater. He'll leave the theater. Now the patient is taken care by a perfusionist who runs this heart-lung machine. Then once the blood has been bypassed from the heart is now a empty sac. It is like an empty sac. Now you can do whatever you want to do it with the heart. You open the heart, fix what you want to fix. If you want to fix a valve, you fix a valve. You want to do a bypass, you take a vein and you bypass. You can do whatever you want to do it. Then you close it. Once you close the heart, now the heart is back normal. Then you take the cannula out, wean the patient from the machine, then the blood will be started going in the heart again. Then you call the anesthetist back. Now the machine will take over his thoracic cavity of the lungs. Then the patient will go. We cannot extubate this patient straight because the patient will be too weak and the wound needs to heal. So the patient will go to the CT ICU, be there for 2 or nowadays it can be 1.5 days, 2.5 days, depending on the health condition of the patient. Then the patient's tube will be removed. So I give you a glimpse of it. So it is a multi-team involving in that. So unless you worked in a cardiothoracic theater, you will never understand these things. By reading how many textbooks, because when I was a student, I never understand this medical surgical, when it says it is being connected to the heart lung, I'll be thinking, what is this machine, what it does? Now going in, this is just another little information about scars. I mean, I'll leave this to you because depending upon where you want to operate, depending upon the procedure. So imagine if I want to do a CABG, you can see the median sternotomy. That is an approach where I open the center of the thoracic cavity. Imagine if a patient is having lung conditions after chronic smoking and other things, all his lung is all been damaged, and you want to do, or he has a cancer in his lung, you want to do a lobectomy, depending on which side of the room. If it's a right side, I go right side up, left side. So you can see the incisions on the right and left of the chest. Implantable cardiac devices. So imagine if a patient is having a pacemaker or an internal defibrillation, then the incision is on top of his heart. There's a little device which you put it to in order to make sure the patient is getting the right rhythm. There's so many incisions. I just thought if you see the scars, it'll give you an idea where exactly and what kind of procedure is being done. Am I making it clear? I know I'm really sorry. We live in a period now, it's all Zoom. We cannot make it any clearer than this. And I'm not very good in explaining as well. So do apologize, but I'm trying to explain with more pictures so that we can get a bit of idea on these things. So again, now the picture has nothing to do with surgery. So just don't get confused with the pictures. So you can see types of cardiac surgery. The first one is called the revascularization surgeries, which is like the CABGs, or adult cardiothoracic surgeries like valve surgeries are called this one. So adult cardiac surgery is dominated by coronary heart disease and surgery. Second thing is thoracic surgery. So if you talk about cardiothoracic surgery, you've got an element of cardiac surgery, you have an element of thoracic surgery. So where we do thoracic surgeries, imagine if you have a cancer of a lobe of a lung, so we need to take a lobectomy, or his whole lungs, pneumonectomy. So if you want to take the full part of the lungs, or if you want to take nodules from the lungs, which cause the cancers, so that is called thoracic surgery. So depending on which lung, we position the patient according to it. Last one is called the congenital things, because you have a lot of children born with congenital anomalies in the heart, so which will have a touch base on it, because it depends on the septum or depends on underlying conditions. That is called the congenital deformities. First thing is the most commonest cardiac surgery, which is called the CABG, or in other terms, it's called CABG. If you work in a cardiothoracic theater, it's called CABG. So heart bypass or coronary bypass grafting is surgery done to improve the blood flow to the heart. It's usually done in adults, because we adults, we either have a very bad lifestyle, we smoke a lot, or we don't do enough exercise, our food habits. Again, it can be genetic. You might have a person who's having a very good lifestyle without cigarettes, without alcohol, still can end up in a CABG theater. Unfortunate, it might be his genetics causing this thing. So if you refer back to pathophysiology, what it does here, the blood vessels which supply to the heart are called coronary vessels. You know that. So inside the coronary vessels, you start getting deposits. These are called the atherosclerotic patches. They are like fatty deposits which sits onto the lumen of the vessels. So once it starts building up patches on the vessels, what will happen? Slowly, your blood vessels to the heart starts becoming lesser. At one point, the patch completely covers, no more blood supplies. Then it causes myocardial infarction. In other terms, it's called heart attack. To a certain point, you can help these patients either by drugs, or you can help them by endovascular surgeries, which is like angioplasties and stenting. But when the patch becomes bigger and bigger and becomes too calcified, we cannot do anything for these patients, because the total blood supply to the heart has been stopped. And there are major 3 or 4 vessels which give enough blood to the heart. And these blood vessels arise from the arch of aorta on the proximal part where the arch of aorta arises, and then it supplies the heart. So when these blood vessels get calcified, heart is getting neglected. So what we do is we got something called bypass graft. So what you do is basically you take another piece of vein, either from the leg or even arteries from the hand. You go take this piece of vein or artery. Then what you do is you go to the heart where the arch of aorta comes. You make a hole on the arch of aorta, patch this vessel, take the end of the vessel, go and patch it on the heart itself. So imagine that's your heart. Your arch of aorta starts from there and goes down as an descending aorta. So what you do is you take a piece of vein, you put it onto the arch of aorta, then you got good blood coming through that and attach it to the heart. But you need to understand, whatever we do, this vessel is from our own body. Another problem here is this vessel itself can become calcified or have an atherosclerotic patch another 10 years down the road. So after a cardiac surgery, a patient has to again change his whole lifestyle. He has to be sticking onto a good dietary, good exercise pattern. Otherwise, what will happen? Even these vessels will start getting things. That's where what happens is, if it's a young person, we can do a redo cardiac surgery, redo CABG. It's all higher risk surgeries. But I have seen in the past where we do a redo surgeries. And again, depending upon how many vessels are being obstructed, how many grafts we need. So if you see in India alone, we do around like 60,000 CABGs. I don't know, is this in the government side or on the private side? Sorry, I don't have the Indian data, but this is what I got in online. And depending upon the nature of the bypass, so if it is like one vessel, you do a single bypass. If it is a double vessel or a triple vessel, the more the graft, the more the time, the more the complications are. So what is my say here is earlier intervention is much more good. So by doing an echocardiogram and also doing an angiogram, you can tell exactly where the blocks are. Then these patients get placed in the theater. then according to the amount of how many vessels are being affected, we take amount of grafts, we patch it up. So here, when you talk about CABGs, you got two techniques here, which is called on-pump case and off-pump case. Understand this terminology here. On-pump and off-pump in cardiac thoracic surgery can only apply for CABGs. We cannot do on-pump or off-pump in other cardiac surgeries. Refer myself back to where I started, where I said open heart surgery and surface heart surgery. So an on pump or an off pump can be only applied in CABG. We cannot apply on pump or off pump in pediatric surgery, because in pediatric surgery, it is always on pump, because you have to cut open the heart, expose where the congenital anomalies are. We need it. So when you cut open the heart, obviously we need to bypass the blood. Whereas in CABG, you have an option here whether you want to bypass or you want to do it as a beating heart. So just to give a bit of knowledge into it, CABG is done for revascularization of the heart. We are not going into the heart. We are not cut opening the heart. We are working on the surface of the heart. So we have an option here whether we're going to use the heart-lung machine or not. This kind of patient selections can be done by the surgeon himself, because he knows it depends on how young is the patient, how many vessels is the patient. Because if you have a very sick patient, it is very hard for you to do it on pump, which means a beating heart. The heart will be beating and you will be working on a beating heart. So imagine if you're trying to write a piece of article in a train, your train will be going like that, and you're trying to write something in a piece of paper in a moving train, you cannot do a job. The same way in an off pump, otherwise an off pump is called a beating heart. Do you understand? The heart will be beating. We don't involve the heart lung machine. The heart will be beating like this. The anesthetist will be still intubated. It will be on the patient. The heart lung machine is not there. The heart will be beating. Then you take a piece of vein from the leg or hand, you go and make a little hole onto the arch of aorta. We have clamps which can hold the aorta. Then you suture the graft on the arch of aorta, take the vessel, the heart will be still beating. We have certain pieces of equipment which we called Octopus and Starfish, which is like a little suction device. What we do is we go hold the heart like this and lift the heart. So now the heart will be upside down so that the surgeon can see. Then what he does, he have to do it very quickly, because now you're tilting the heart upside down. It starts messing up with the blood pressures and other things all. You have to do it very quickly. So when I say you have to do it very quickly in off-pump cases or a beating heart, that means your patient should be young and healthy. We cannot do beating heart surgeries in a very sick patient, because the moment you touch the heart, his pressures all start playing out. We cannot do it. For these patients, we have to put the patient onto a heart-lung machine. Am I making sense here? Am I making sense here? And also when you do congenital disease, we have to do heart-lung machines. So don't confuse. So off-pump or beating heart only for CABGs. Whereas when it talks about other cardiac surgery, you have to use heart-lung machine, because you will be bypassing the blood, because you'll be working inside the heart. Have I made it clear? So on pump, off pump, again, it has its own advantages and disadvantages. On pump, where you're getting the blood into a machine. So obviously the blood is coming out of the human cavity, infection risk, we are using medicines here, nothing solved. But for certain diseased patients, for a triple vessel disease and other things all, we have to use them on pump cases. Yeah. So that's a bit of CABG. Hope I didn't confuse you a lot, and because it's a quite big topic and very complex topic, and hope I don't want to give too much information and confuse your team there. Again, so now going back, forget CABG. Now we are talking about heart-lung machine. Now, when I said I will be putting cannulas here, I'll just going to show you this one. Look at this picture here. If you see the picture here, that's a classic picture of a heart with cannulas in. When I say cannulas in, cannulas are like little tubes which you put it into the heart, drain the blood. So again, you know, in the heart, we receive dirty blood, we pump it to the lungs. Lungs will oxygenate and clean and bring the blood back through into the heart. From the heart left ventricle, the blood is given back through the arch of aorta. A very quick pulmonary cardiac circulation is the dirty blood comes from inferior vena cava and superior vena cava, enter through the right atrium. From right atrium, the dirty blood enters through the right ventricle. From right ventricle, the dirty blood travels through pulmonary artery to the lungs. When it goes through the pulmonary artery into the lungs, the oxygen exchange happens. The blood gets cleansed. From the lungs, it comes back into the heart through a pulmonary vein, enters into the left atrium. Then from left atrium, it goes into left ventricle. From left ventricle, through the arch of aorta, it comes out of the heart as a clean blood. This is your cardiac circulation. Am I making it clear here? I bet you would have learned, if you're all in your MSCs and BSCs, you would have learned your cardiac circulation here. I just want to share something very interesting here. If you see in the whole body, pulmonary artery is the only artery which carries unoxygenated blood. If you look into the picture here, the dirty blood enters through the dirty blood comes from the inferior vena cava and superior vena cava, enters the right atrium, then goes into right ventricle. From right ventricle, the dirty blood, the unoxygenated blood, enters into the lung. The vessel which carries is called pulmonary artery. So in the body, the only artery which carries an unoxygenated blood is pulmonary artery. Very interesting, isn't it? So, but even though pulmonary artery carries dirty blood from the heart to the lungs, I don't know how I can explain to you. You see, the function of an artery is carrying blood away from the heart. So even though it didn't tick one description of carrying oxygenated blood, it ticks the other description. So example, I'll make it very clear here. Artery means what? Artery means carrying oxygenated blood. Artery means carrying blood from the heart to the tissues. Here, a pulmonary artery carries unoxygenated blood, but it carries blood away from the heart. So it carries from the right ventricle to the lung. Have I made it clear? And then the same way it applies for the pulmonary vein, which carries blood from the lungs back into the heart, where a pulmonary vein is the only vein which carries oxygenated blood. But it ticks the second box. A vein means it carries blood to the heart. See, a vein carries blood to the heart. Here, a pulmonary vein carries blood from the lung to the left atrium. So it's a bit of like a bit of little fun here, the way the body works here. So you're going back into the cannulation of the heart. So you can see the venous cannula. If you see the picture very clearly, the venous cannula enters through the right atrium and goes. Then what it does is venous cannula, the vein itself collects the dirty blood. Then the dirty blood is taken from the right atrium and right ventricle, goes back to the machine, the heart-lung machine. The heart-lung machine does the work of the heart and the lung, which is basically cleaning the blood, enriching the blood with oxygen, warming the blood, and giving it back to the body. So how it comes back to the body? If you see, there is something called aortic cannula there. If you see that, it goes into the aorta. But in order to do all these things, what we need to do is we need to put the cannula first in. So what the surgeon needs to do is he make a little incision in the heart. He puts the cannula. This all has to be done very quickly because because you won't have enough time and the blood is pumping in the heart. You have to do it very quickly. There is no element of mistake or anything. The cannulation should happen very quickly. And these are quite big cannulas. So when I mean cannulas, they are not like your Venflons or your arterial catheters. These are quite big, which are in dimension. It'd be like the venous cannula is around like nearly 15 millimeter, and aortic cannula is around like 10 millimeter. So that big in nature, in order to collect the whole blood. And once the whole blood has been going through the blood gas machine, sorry, the heart lung machine, what you need to do is you need to now stop the heart. So going back, how are you going to stop the heart? We use a drug called cardioplegic drug. A cardioplegic drug is basically a high concentration of potassium. If you see, you can see on the chart, it's called cardioplegic drug. Plegic means stopping. So we use a drug to stop the heart because we have to work on the heart. For working on the heart, you need to stop the heart. Let me just give you a break here because I think it's been nearly 1 hour now. So let me give you a break, and I'll be very quick. I'll give you a break of a couple of minutes, then we can have a catch up, and so that you're not drained completely. And hope I'm making sense here to you all. Sorry, we're not getting a feedback from you. எல்லாரும் screen off பண்ணிட்டு வீட்டுக்கு போயிட்டீங்கன்னா கூட தெரியல.
No, sir, no.
No, I thought I'll give them a break. I thought I'll give them a break. ஏன்னா it's a quite big topic. இதை எவ்வளவு இன்ட்ரெஸ்டா நடத்த நினைச்சாலும் ஓரளவுக்கு தான் நடத்த முடியும்.
No. This is very much interesting, sir. We are just dived into the ocean, I think.
மேம் இது வந்து எப்படின்னா
Okay, ma'am.
நாங்க படிக்கும்போது when we study, there are certain concepts we can't understand in medical surgical book because we never been in a theater. அதை பார்க்கும் போது நம்மளுக்கே தெரியாது என்ன திடீர்னு ஹார்ட்ல கேனலா போடுறாங்க, how this works. And when you work in a theater only, we'll understand this inner concept. I mean, and with this corona and other things, all medical surgeons sort of missed their whole clinical placement as well.
Yes, sir, really.
I just thought I'll give them a break. Another or 6 or 7 slides are there. Once that's done, and then the children can go back.
Yes, sir. We'll have 5 minutes break. Participants can have 5 minutes break.
Yeah.
Okay, we'll start shortly.
Yeah. Now the time is
now it's 10:40. We'll join
10:45.
Yeah, I hear it is 10:40.
We'll meet.
Yeah, 10:45 we'll meet.
Thanks, என்ன லூக்கா ஆல்ரெடி இது பண்ணியாச்சு. So I think ஆரம்பிக்கலாமா?
Yes, sir.
Okay. So just to start, I mean, we don't want to jump back straight into the topic. The thing is, sharing my own reflection, I worked in cardiothoracic theaters to start with, then I worked in orthopedics and other things all. The only theater which is very hostile and very tensed is cardiothoracic theater. That's purely because if you look into it, the moment you start touching the heart, if you start opening the heart and touching the heart with the instruments, the heart starts playing up. And it's very hard because the heart controls the whole blood pressure and other things all. It will be very hard to do it. So why I'm telling that is, now I used to work with a cardiothoracic surgeon back in India. He was a genius. This guy is all brilliant, and they are lifesavers. His name was Prasad Krishnan, and he was an associate of Girinath. இந்த பேர் உங்களுக்கு நிறைய பேர் தெரிஞ்சிருக்கும், Girinath. He was an Apollo surgeon. And Prasad Krishnan அவ்வளோ கெட்டார்து பேசுவார் தியேட்டர்ல, பயங்கரமா திட்டுவார் நர்சஸ் and doctors, and because of the stress, and the moment we do something wrong, we all been பயங்கரமா கெட்டார்துல சொல்லி திட்டுவாரு. ஆனா அடுத்த நிமிஷம் வெளியே வந்துட்டேன்னு வச்சுக்கோங்களேன், then he becomes absolute normal. He start talking about cricket, cinema, அதை பத்தி பேசுவாரு. The whole environment, it's out of the whole surgical, every specialty, heart is the only one you will never know what is happening. Because I've done brain surgeries, we have worked in brain theaters, we have worked in neuro theaters, we have worked in pediatric theaters, we have worked in neonate theaters. இங்கெல்லாம் வந்து பாத்தீங்கன்னா we operate on, even the smallest I've operated is 450 grams. So ஒரு குழந்தை 450 grams ன்னு சொல்லும்போது it is only a size of என்ன சொல்றது, ஒரு பிரெட் லோஃப் மாதிரி இருக்கும், இவ்வளோண்டு தான் இருக்கும் அந்த குழந்தைங்களுக்கு கூட. But out of all the surgeries, I think cardiothoracic is the most hostile because it touches the heart. When it touches the heart, it's everything, every parameter starts changing, and the most important thing in your whole body is the circulation and your blood pressure, and that is controlled by the engine, which is the heart. I have to be very careful. So I just thought I'll share that with that. So if you work in any operating theaters, the cardiothoracic is the most hostile one. So going back into this cannulation. So as I said, we use cannula to drain the blood from the heart. So we use a venous cannula entering into right atrium and right ventricle. You use an aortic cannula. You see the pictures very clearly. Aortic cannula, an arrow காட்டுது. It is bringing blood back from the machine into the heart, which is oxygenated blood given back into the thing. Now, if you see both the cannulas, between both the cannulas, venous cannula and aortic cannula, there is another cannula which is called the anterograde cardioplegic cannula. So this is very important. Reason is because that is the one which gives the drug to stop the heart. As I mentioned to you, in order to work on the heart, if the heart is keep on moving like that, you cannot do it. So we have to paralyze the heart. If you want to paralyze the heart, we need something called a cardioplegic drug. As I mentioned, a cardioplegic is a high potassium and a sodium chloride magnesium combination drug. We use this drug to deliver into the heart and stop the heart. You might ask me a question here. If I give a drug into the heart like that, will the drug not go back into the machine or go back into the circulation? Look at the picture carefully there. Between the two cannulas, there is something called cross clamp. நீங்க அந்த clamp பாத்தீங்கன்னா தெரியும், the cross clamp goes across aorta, occludes the aorta completely, then you got the CP drugs given here. That means what? Before, when I started the seminar, I said the heart is being supplied by blood vessels originating from the beginning of the arch of aorta, which is proximal of the arch of aorta. If you see the clamp is between the proximal part and the aortic cannula. So idukku nadula when we clamp it, that means when I give the CP, the cardioplegic drug, when it goes in, it won't go back into the peripheral circulation. The clamp will stop cardioplegic going back through the arch of aorta, getting back into abdomen aorta, descending aorta, and it won't happen. If you see the clamp clearly, so the clamp protects the drug entering into the peripheral circulation, because if the blood enters the peripheral circulation, we might having paralysis of other organization because it's a high potassium drug. Do you get that? If you see the picture will clearly explain you that. So now, again going back, this is a kind of a schematic diagram, how simple we can explain a heart-lung machine. You can see the IVC and SVC opening into RA. From there, we got the venous return line. Can you see the venous return line, which enters the heart-lung machine? You got something called reservoir. Then you got bubble detector, because what we are now doing is we are now cleaning the blood. We got something called bubble detector. You don't want any air in that line. If there is any air on the line, what will happen? If you see, again, the blood gets cleansed and go back into the arterial inflow. Then we might put air into the circulation. If you put air into the circulation, what happens? Then it go lodge in various places, can have a pulmonary embolism or a VTE, or even have a stroke on a patient. So imagine it goes and lodges in air lodges in the brain. You can have, so the bubble detector will detect any bubbles in the blood coming into its centrifugal pump. Centrifugal pump is a pump which rotates in high speed. When you rotate the blood in high speed, you get all the dirty things out of the blood, then clean the blood, goes into something called heat exchange. Again, this is what our heart does and our lung does. It gives heat to the blood. Again, we go mix it with oxygen. It's called oxygenator. From there, you can see in the diagram, you can see a blue diagram becomes into red. That means what? You're cleaning the blood and it becoming red. Again, goes into flow meter, goes into filter, gets back into arterial inflow. In this diagram, if you see, the heart-lung machine is a machine which also gives the cardioplegic drug, and it goes into the separate line, which is called the anterograde cardioplegic drug. Ana in the rendu line ku nadula pathina, there is something called aortic cross clamp. This clamp is very important, because if this clamp is not there, the CP drug, high potassium drug, will go into the whole peripheral circulation. The whole body will get high potassium. Am I making it clear? If you see the picture will make it very clear to you. So now the heart is completely emptied. The heart becomes like a kaathu pona pandu mari irukum. Then you do whatever procedure you want to do it. If you want to do a revascularization, CABG pannalam. Otherwise, if you want to open the heart, you go and do the congenital deformities. So the most commonest surgery in adult is the CABG, which we call the revascularization of the heart. We take vessels from various parts, we do that one, we come out. Once that has been done, then we go, at the end of the procedure, once everything has been done, we reverse the heart. So in what you call the reversal of the heart is, To begin, we would have given drugs like heparin. We have to give heparin because the blood is leaving the body cavity. You don't want the blood to become clotted. So we give heparin in the blood. We give cardioplegic in the blood. In order to reverse that effect of it, we use a drug called protamine. So we give protamine. When we give protamine, it reverses the effect of the heparin. If you learn pharmacology, protamine reverses the effect of heparin. It reverses the effect. Then what will happen is, then all the heparin has been taken out from the blood. Blood becomes normal. Then what you do is you start taking one cannula after one cannula when the heart is completely full. And by the time all the blood from the machine would have come back to the heart, then we clamp the clamps, we take the cannula out. Wherever we made holes on the heart, we stitch it. Have I made it clear here? Then the procedure is finished. We take the patient to the ITU. So that's where it stands.
Wow.
Now, sorry. Any questions on that?
No,
Okay.
sir.
Okay. So now, when we started, we talked about different type of cardiac surgeries. One was cardiac surgeries. Next was thoracic surgery. So in adult cardiac surgeries, mostly it is CABG and also valve. So valve surgeries are mostly done on elderly patients who have rheumatoid fever and rheumatoid arthritis. So what happens is these rheumatoid plaques go and deposit on the valve. Valve are the one which open and shuts in this atrium to regulate the blood flow and also the blood pressure. So when these valves cannot do the function, what happens is the blood cannot go and cannot flow in the particular aspect. So what we do is we open the heart. Again, the similar setup. We anesthetize the patient, put the patient on the table, connect the patient to heart-lung machine, open the heart. So if it is mitral valve, a mitral valve is presented between right ventricle and pulmonary artery, which opens the dirty blood into the lung. So we go mitral valve excise panni, we'll put an artificial valve on there. If it is an aortic valve replacement, then we go to the left ventricle, open the left ventricle, find where the aorta starts. The valve will be sitting. Valve is basically like a toll gate. A toll gate, open, shuts, open, shuts. Why it open, shuts? It regulates the blood flow and also the blood pressure. So in a rheumatoid fevers and other things, all these valve becomes calcified and they cannot shut up properly. So we have to excise this valve, put an artificial valve on it and put it on aortic valve, then the patient will have the same setup. How the valve works, it works in a similar setup. When the blood in the it is like a little lid. When the blood starts hitting, when it causes systolic, diastolic padikumbodhu, when the blood starts pressuring, it hits the valve, it opens the valve, shuts. It works in a similar setup. So that is adult surgery. Then we talked about thoracic surgery. Now we are going into pediatric surgery. So pediatric surgery is congenital anomalies. So these are the children who are born with a defective heart. Either there might be a problem in patency or there might be a problem in the septal. So the most commonest is called the patent ductus arteriosus. I don't know how many people remember embryology, or I think Selva raised her hand. She wants to ask a question. I don't know. Someone raised the hand. Is that okay? Can I carry on or?
You just proceed, sir. We'll have
Anyway, there will be an
some
end
practical
session. We can ask questions on that.
Yes, sir.
So if you go back to embryology and we see the fetal circulation happens where mother's umbilical vein will bring the oxygenated blood into the fetus and then enters through the ductus venosus into the right atrium. Then the blood doesn't go straight into the arch of aorta. It goes through a patent ductus. If you see the picture here, this is a classic example of a patent ductus arteriosus. When we see this picture, you can see the dirty blood, which is blue blood, from right atrium, right ventricle, goes into pulmonary artery. You can see the two flap. That's where the pulmonary artery starts. Goes into the lung, ana, but we can see here clearly where the pulmonary artery and then the arch of aorta, there's a little lumen, little duct. And this is called ductus arteriosus. when the fetus was in mother's womb, this will be open because that is responsible for the fetal circulation. But when the child is born and comes out and takes his first breath and second breath, that should start closing. In this case, it doesn't happen. It is left open like that. So what will happen if it is left open like that? When the child is born, you can see clearly the blue part is the unoxygenated blood, which goes through the pulmonary artery, and the unoxygenated blood enters the arch of aorta. That means what? The whole body is getting an unoxygenated blood. But it is not a life-threatening scenario because still the arch of aorta is able to get clean blood from the left ventricle. So it is like a minimal leak. Nama tapla chinna leak irukka mari, there's a little leak. In many cases, a PDA closes as a child goes bigger and bigger. But as the day goes, sometime when the defect doesn't get closed, and what will happen is when the child becomes bigger, the oxygen demand, our oxygen demands become bigger, the body cannot cope. These are the children where you'll see when the child becomes 4 or 5 years, they'll say, oh, he's getting too tired in the school. He cannot run the 100 meters. He's getting too tired. Then you go, what is the problem? Then you do, he'll be absolutely normal. But there is a little bit of mixture of oxygenated and unoxygenated blood. Then if you do an echocardiogram, then you'll say, oh, there is still an opening. Then these patients go for a quick surgery. And to be honest with you, patent PDA is a commonest congenital deformity, but can fix within 20 minutes. It is so simple because you don't have to put the patient into heart-lung machine. You don't have to do anything big. You anesthetize the patient, do a little opening on the chest, find out where is the lumen and the opening engan paathu, go clamp the loop, stitch it. That's the end of the story. Then the channel, and the chinna and the adappa, we have closed it off. End of the story. And the child becomes absolutely normal. These procedures only take like half an hour to 45 minutes. So that is called patent ductus arteriosus, a very commonest congenital deformity. Second one is called arterial septal defect, which is, again, that word itself says there is a problem between the septum of the heart. So heart is made up of 4 chambers: right atrium, right ventricle, left atrium, left ventricle. And the atriums are being separated by the atrial septum, and ventricles are being separated by the ventricle septum. So here in AST, you can again see in the picture how a dirty blood of blue blood comes into the right atrium. And you can see the opening between atria where you can see the oxygenated blood is mixing up with right atrium. What is the problem here is, the problem is that again, a child will survive with an AST for longer time if you have a hole in the heart. I had a cousin who had a surgery, an 18-year-old. Till 18 years, we didn't find out that the child had an AST because you can see the oxygenated blood, because we all know that left ventricle is much more powerful organ and it has much more pressure. So put it this way, the red blood is only coming to the blue blood. That means what? The body is keep on purifying the red blood again and again. So these children's, actually, you won't even know whether they had an atrial septum till they become like 2. Again, then they start running in the school, when they do physical activities, when they do, or 18 years, when they start swimming and other things, all the child becomes easily tired. And you say, why are you becoming easily tired? Because here, the body is doing the same job again and again. The red blood, the oxygenated blood, keeps coming back into right atrium, gets again purified. It is like doing the same job again and again. The body gets easily tired. So if you see here, what we need to do is, this procedure takes 1 hour. But what you do is, when you anesthetize the patient, put the patient onto the heart-lung machine, because as I said earlier, all the congenital deformities, we have to open the heart to see where is the problem. We cut open the heart. So here we cut open on the right atrium, where we find the opening between the right atrium and left atrium, where you got the dirty blood the clean blood is keep circulating. Go find out the opening, it might be something like that big to that big. If it's an adult, you will have it that big. If it's a child, it might be very little. Find the hole, close the hole. Most of the time, if you're operating on a child, the hole be too small, you can close it. But sometimes the hole might be too big for an adult. Now, we cannot bring the cloth together and stitch it. We can't do that. Here, we use patches. So we got something called Gore-Tex patch. Nama shoe ku podra leather mari, it'll be in a thick leather. You go, find out where the defect is, patch the hole, you stitch it on. Then the child becomes absolutely normal. These kids won't even feel anything. It's called AST. Again, similar kind of thing, which is called VSD, which is called the ventricle septal defect. Here, look at the problem again here. Again, blood comes through the right atrium, enters the right ventricle, but you can see opening between ventricles. You can see where from the left ventricle, the blood comes again. Again, it is not a grave problem because your blood from a higher pressure area, which is the left ventricles, come into the right ventricle, which means the body is again doing the same job, which is the clean blood has been keep circulating into the body. It's like doing the same. So the patients get easily tired and other things. So ventricle septal defect is also not a grave problem. It is all easily cured. Again, depends on the space. We either bring the ventricles together and close it. Otherwise, we take a patch, put it between the ventricles, and we close the ventricles. Safely done. But next commonest complication with pediatric is called TOF, which is called the tetralogy of Fallot, which means tetralogy means 4 types. So it has 4 complications in it, and we have to cure the 4 complications. So you can see the first one is an abnormal opening or ventricle septal defect. So here the patient has a ventricle septum. So again, it is here you got a VSD. You can see the blood going from right ventricle to the left ventricle. You hear this is a much more serious problem because here it's not because of the VSD. If you see the narrowness or just the pressure, the pulmonary valve that partially blocks the blood. So what happened is here, you got the dirty blood coming from the right atrium, entering into the right ventricle. Normally this dirty blood should go to the lungs using pulmonary artery. But because the pulmonary artery is narrowed, there is no escape of this dirty blood into the lungs. Pulmonary artery, right ventricle starts becoming bigger and bigger. When something becomes bigger and bigger, it starts generating more pressure. And what will happen at this point, when it starts generating more pressure, you got dirty blood entering into the left ventricle. Can you see that? Yeah. So if you see this picture here, it is similar to a VST, but the only difference is there is a narrowness of the pulmonary artery. When the pulmonary artery becomes narrow, it is not taking the blood from the left ventricle. The blood is staying back in the left ventricle. That means what? Here there is a shunting of blood from right ventricle to the left ventricle. In VST, there was a shunting of blood from the left ventricle to right ventricle. That means we are pushing a clean blood back into a dirty area. But here, you're pushing a dirty blood into the left ventricle. That means what? Your body starts getting dirty blood. Because if you see, and the blue becomes a bit purple and enters into arch of aorta. That means what? Your body starts getting dirty blood. So these are called cyanotic heart diseases. If you see the congenital anomalies, you got cyanotic babies, acyanotic babies. So AST and VST, if I go back on the slide, in the padina here in VST, you see the arch of aorta has red blood. That means the body is still getting oxygenated blood, no problem. Even in AST, arch of aorta is carrying red blood. In PDA, the arch of aorta is carrying red blood. All these above conditions, the body was getting oxygenated blood. But first time in tetralogy of Fallot, the arch of aorta is carrying a purple blood, means it is a dirty blood. That means the body is not getting enough oxygen. So these are called cyanotic babies. They're called blue babies. And again, there's one more condition called thickening and enlargement of right ventricle. As I said, because pulmonary artery is narrowed, right ventricle started getting more blood. The more it gets getting the blood, the right ventricles become bigger and bigger. And again, there's another problem is arch of aorta is overriding, putting pressure on right ventricle. Obviously, all the dirty blood will shunted from right ventricle to left ventricle. I know it's a bit confusing, but if you sit down and analyze these pictures clearly, you can make sense out of it. All right. And the last one here we're going to talk about is TGAs. So these are called the blue babies. So when you talk about these TGAs, unfortunately, it is the most critical babies. So here you can see TGA stands for transposition of great arteries. So here the pulmonary artery arises from left ventricle. Lala paranga, if you see the diagram, PA originates from left ventricle and aorta originates from right ventricle. That means what? Transposition, complete change in the anatomy. It's a total reverse anatomy. That means what? The whole body is getting unoxygenated blood. The blood is not being oxygenated at all. So if you see, these are the babies which are born absolutely blue. And what happens is normally these patients need to come to theaters immediately. So normally for ASTs, VSTs, and TOF, we can wait till the baby becomes much more bigger. Whereas in TOF, TGA, we have to bring the baby straight. I don't know how many people we know that our size of our heart is our clenched fist. So my heart size is only this much. Imagine a neonate heart, which is born 3 kilograms, will be a size of an இளந்த பழம் அந்த மாதிரி சைஸ்ல தான் இருக்கும், இவ்வளவுதான் இருக்கும். It'll be a little and I don't know, I can't examine. So it'll be very little, and trying to work on such a little space, surgeon is so hard. Again, another thing is in TGA, the problem is because the child has the deformity when the child was in the intrauterine, the child adapted certain technique. What will happen is here, when this child are born, the child is blue in color because the body is not getting enough oxygen. But when we correct this deformity, so inside the theater, I have worked with a cardiothoracic surgeon. I've done 2 or 3 TJs because it's very rare, and normally these babies don't survive. When we do TJs, out of 3 cases which I've assisted to the particular surgeon, Mr. Prasad, only 1 survived. So we would have started the case morning 8 o'clock, finished the case midnight 12 o'clock. After what? This is like nearly 16 hours of surgery on a little baby of this size. The baby dies. Very, very sad thing, but that's the nature of it. We have heard a term called surgery success, but the patient died. So these applies to these ones because here the surgeon would have corrected the deformity. What he would have done is he would have closed the ductus, he would have closed and made the opening of arch of aorta and left ventricle. We would have done everything. But once we've done all the corrections, clamping and bringing the cannula out, the patient won't recognize it because the child all throughout 10 months in the mother's uterine would have learned this anatomy as a normal anatomy. Am I making sense here? So the child thinks this is a normal anatomy, but when the child is in mother's uterine, it is normal because you're only getting oxygenated blood. Whereas when the child comes out into the earth, this normal anatomy, which is normal for a 10 months when it was in uterine, cannot cope. Namma enna surgery panni, we would have corrected this deformity. The child cannot recognize it. Poor child, which is little. So every time we cannulate it, the child won't recognize the switch. Still doing it. Pressures cannot be maintained. Unfortunately, after 16 hours of surgery, we have to give up the child. Very sad, but even the prognosis for this kind of TGAs are very sad, actually. I mean, these babies don't thrive very well. They'll be very, what you call, they cannot gain weight. They'll be very skinny. Those children which survive the switch, the procedure is called switch because we change the TGA. These children don't survive very well. So these are the commonest pediatric, as we talked about PDA, ASTs, VSTs, are acyanotic congenital deformities. Conditions like TOF, TGA are cyanotic, means like the body is getting unoxygenated blood. Emergency surgery has to be done. There are plenty of other children's congenital, but it is so extensive. But I've just picked up these 5 because these 5 are the commonest congenital deformities which you normally operate on. Again, now we're going back again into theaters. What is going to be the future of cardiac surgery? Future is a lot of robotics are coming in to do cardiac surgery. Again, in terms of vein harvesting, we started doing endoscopy and other things. All if you see the last term here, transcatheter aortic valve. Although the earlier times we have to open a heart to replace the valve. Nowadays, using angioplasty technique, the pinhole technique, we can pass needles, pass guide wires, and these valve will be shut into a little form, will be pushed through the vessels, go into the aorta, then they open up, like how we open a parachute open. When we come in a parachute, we come down, we descend, we open the parachute becomes bigger. Same way nowadays, the valve can be wrapped up into a little peanut mari, chinna verkala mari madichu vechittu, then you pass through the vessels, you go into the artery. How you do an angioplasty and stenting, you go where you want to deploy this valve, you deploy it, it opens. That's a new technique called transcatheter aortic valve replacement. Endoscopic vein, earlier times எல்லாம் பார்த்தீங்கன்னா கால்ல வந்து இப்போ நீங்க CABG பண்ணவங்கள பார்த்தா தெரியும், கால்ல பெரிய இன்சிஷன் இருக்கும், தொடையில இருந்து கால் வரைக்கும். Nowadays all done endoscopic, make a little incision, then you pass a tunnel through the ஒரு tunnel மாதிரி இருக்கும், அந்த tunnel bore tunnel மாதிரி இப்படி சுத்தி போய் it takes the vein, snaps the vein, bring it down. So that's a new technique in future of the cardiology. Again, look at this is a classic example of a cardiac theater. So you can see the big machine on your left hand side is called the heart lung machine. As I said, how it takes the blood, it has purpose. Over chamber kum purpose irukku. One is oxygenator, one is heat exchange, one is a CP drug and other things. So, and it given back. I'm sorry, I have to rush up because I'm a bit mindful of the time. So this is a classic example of an operating theaters. Again, communication is very important. You see, because you got a lot of people working in the theaters. A scrub nurse has to communicate with the surgeon. A surgeon has to talk to the scrub nurse. We have to talk to the perfusionist. But when he says clamp, you clamp the line. There is so many things, and communication is so vital in these cardiac theaters, because that is the reason when you work in a cardiac theater, you have to be very extremely quiet, polite. You have to think there shouldn't be any friction in the team. If there's any friction, then you can obviously lose a child. There's so many things in this cardiothoracic theater which makes it so. Communication is vital in this kind of theaters. And again, cardiac theater teamwork. It is just not one individual, it's a teamwork. Who's in the team? You got surgeon, you got the anesthetist, you got the surgical first assistant who assists the surgeon, scrub nurse, circulating nurse, you got a HCA, you got a cardiologist, you got perfusionist, you got the intensive care clinician. You know, there is also an intensive cardiologist, purely because these dynamics now and then changes. So you need someone who knows this knowledge in the theater. So he will be there, ITU consultant will be there. That's it. End of the story. I know it's been a long presentation. I know a lot of people would have got bored. You would have started drawing in your papers. But unfortunately, the classes like this, Ganeshans gave me 2 hours. 2 hours is too long for these kind of classes. Any questions? உங்களுக்கு சொன்னதெல்லாம் புரிஞ்சா, இல்லனா நீங்க பாட்டு கம்ப்யூட்டர் ஆஃப் பண்ணிட்டு போயிட்டீங்களான்னு எனக்கு தெரியல. But
we have to believe our participants, sir. Everybody is interestingly listening to your class, I think.
I hope so.
Yeah.
I mean, these are things which is too much to comprehend. There are a lot of information which is happening. But my only say here is, I'm more happy to share my email address. I'll send my email address at the end of it. If people got doubt, they can always question an email. I will try to break this concept. And then again, same thing applies for any medical surgical. I say the pharmacology pathophysiology because I don't know these things. My knowledge is very simple. I've got only theater knowledge and surgical. இது மட்டும் தான் எனக்கு தெரியும். அதனால anatomy, physiology, pathophysiology இதெல்லாம் கேட்டீங்கன்னா எனக்கு தெரியாது. If I give my sorry,
what is rare experience? You have it, no? So
yeah.
we
So
don't.
yeah, நீங்க சொல்லுங்க.
No sir, no sir. You continue, sir. Yeah.
அதனால இப்போ வந்து if students got any doubts, if there is any concept which needs to be much more elaborated, now I'm more happy to think. I think Nitya BSc raised a hand. She wants to say something.
Nitya, you can unmute. You can raise your queries. Unknowingly she did, I think, sir.
Okay, no problem. So, and if people wants to come back on questions about it, then I know I've covered a so big topic, but then I've just touched base on everything. It's by the end of the day, the students has to go into each and every topic, do their own research on these topics and learn about it. And my only say on this medical and surgical is to the students is always understand the pathophysiology. The same thing applies for even when we do psychology also. Always understand the pathophysiology, then you work your way up. If you
Okay.
Sorry?
No, sir.
No.
Actually, participants are asking me to permit them unmute.
Yeah, please. Yeah. Just
Yeah.
yeah. You can ask your questions.
Participants, now you can unmute yourself. If you have any queries, you can raise your questions.
You won't get an opportunity like this, participants. So, like any small doubt you have also, you can ask. MSc students, definitely you should have a doubt. You should have some doubts. All clear to you? Okay, let them think. We will, we'll give them some time.
That's fine. Absolutely. I
have I have a lot of doubts, but I will kindly request you to extend your sessions for us, because I think this is not sufficient. This is only very, I feel it is very
basic.
Grassroots level. So
yeah, absolutely.
Maybe you can take up one day open heart surgery alone, and other day adult cardiac surgeries, and going for pediatric cardiac surgeries.
Absolutely, ma'am. Absolutely.
Definitely, because we have master's program also. Our master students and even BSc specialization medical surgical is there, and pediatric nursing is there. So they'll be benefited a lot. So this maybe with your approval, we shall plan later. But I should not ask a doubt, but I'm just asking. I just would like want you to highlight what are some of the, as you are working in the cardiac theater abroad, what is the main difference you find between our triple M where you worked, or our Indian setup of a cardiac theater, and your long expertise in the UK? What is the main difference you feel which we are lacking here, or we can do in a better way, our theater system?
Ma'am, I can only comment on triple M, and because I've seen cardiac surgery in triple M and I was working in Apollo.
Okay.
The technology is the same thing, because both are private firms. So and I can't comment on what's happening in the government hospitals. But only one thing which is different from UK is, again, it's money. The technology is the same thing, but again, using of the equipments. So example, which I said, those cannulas, the arterial cannula and the venous cannula. In India, we process it again and again.
Okay.
So we don't, whereas in UK, it's all single patient use, we chuck it in the bin.
Okay.
Whereas in India, we clean it, we send it for sterilization. We do gas sterilization called EO, ethylene oxide sterilization. We process this on and on and on. So by doing this, there is no problem in terms of infection because we would have sterilized this product. But in terms of integrity, because after 10 or 15 years, their purpose is only single use. But we tend to use it because of the cost factor. We cannot afford it for every patient chucking it in the bin. Unfortunately, the integrity is bad. But it's again into the theater. And I'll tell you one thing is, in terms of technology, there's never been a change at all. And the technology in India is similar to what we see in abroad and what we see in UK. The only thing is, in India, it's much more clever. Again, affordability. In UK, we pay tax, we go into the government hospital, we get the surgery. Whereas in India, unfortunately, we have to pay money into private hospital. In government hospitals like ESI, Southern Railway, which is in ICF, is a world pioneering center for cardiac surgery. We have surgeons coming from all over the world learning in it. The same way, I don't know how many people know about these things. In terms of orthopedic surgery, MIOT and Coimbatore Ganga Hospital for hand surgery is world renowned. We have world surgeons coming from every part of the world coming and learning techniques from this part of the thing. So to be honest, the Indian technology is well in advanced, and it's only the affordability is a bit less.
Okay. How about the timing of the surgery? For example, the same bypass surgery, the timing what we take here, maybe 1 hour or latest 1 hour, or like earlier and early it was 4 hours. So the timing also.
Sorry. Sorry. நீங்க முடிங்க.
Yeah, I just wanted to know whether there is any difference in that day.
Ma'am, again, time is money. See, I work in private hospital. காலையில 7 மணில இருந்து 8 மணி வரைக்கும் we work, and we like generators, like we do the more that we do the case, more the money we get. In private, surgeons are very clued up, and to be honest with you, on pump cases are quicker than off pump cases. நீங்க யோசிப்பீங்க, how can that be possible? Because Sam, we are clamping, we are putting a cannula, we are bypassing. On pump cases are much more quicker because the time which we take for clamping, putting a cannula and putting the machine, it is less time, because you can clamp within 5 minutes and we can cannulate within 5 minutes, 10 minutes, put the machine. Whereas in an off pump case, you have to be very careful. And every time you lift a heart or you try to hold a heart with a hand, then the pressure starts playing up. Then the surgeon has to put the heart back or 10 நிமிஷம் wait பண்ணுவாரு for the pressures to all settle back into the normal. Then we start operating again. Whenever it lifts the heart, it plays up again, because as I said, the moment you touch the heart and move the heart and maneuver the heart, pressure starts playing up. In an off-pump case, even though we don't put it in, we'll be half of the time standing there waiting. Again, as I said, the previous example which I gave, how easy is to write on a moving train. The same thing, in a beating heart, it is very hard for us to do a suturing because heart will be constantly moving. Chance of bleeding, and the anastomosis won't be proper. So off-pump cases take more time than on-pump cases. But off-pump has less side effects because we are not using cardioplegic drug. We are not sending the blood outside into a machine. Those kind of advantages are there. In terms of times, UK and India is much more quicker because surgeons are much more clever. And for us, it's time is money. Whereas UK, most of the hospitals are teaching hospitals. So consultant surgeon will let us register to operate. Normally, 3 hours surgery will take 4 hours.
Okay. That is clear. Robotic surgeries, do we have the same? Do we have in India this much robotic surgeries?
We got the same technology.
Same technology, but the number of surgeries we do here same like they.
Ma'am, the answer is in your question itself. the thing is, we don't do that amount of cases purely because of money. As I said, in the robotic surgery, the instrument, the piece of instrument has a life. This has a life. When I dock it, it tells me every life. So on the India, I can't use the same instrument for 100 patients. The machine will tell me every time when you dock it, it will say Sam 7 out of 10. That means I've used 7 times. I've got 3 more life. So we cannot cheat the system here. Robotic is much more. So the option is open to the public. We can do every procedure. Robotic is like a style. It's like driving a Mercedes Benz. You can drive an Ambassador and go from A to B. You can drive a Mercedes Benz A to B. The difference is the time, the luxury. Same way robotic. And India, because I had the rep who comes and trained us, who also went and established robotics in Bangalore and in Chennai, all said they got the same technology. Again, affordability. So if people can afford all this thing, and to be personal, as I said, I'm not a surgeon. I'm not following this patient. So don't get me wrong. This is my reflective view. Do we really have to do it on robotic? Again, because we get the patient into funny positions and extreme position, the time is longer. Yes, it has its advantage, which is a short stay, minimal scar. Again, robotic. The surgeon has to weigh the benefit. So again, because we see so many surgeries, we see many times a laparoscopic turn into an open, bleeding arm, then we have to open them urgently. We see surgeons messing around too much time, and we'll be thinking, why don't you open it and do it and get it done? So I can only comment on a nursing part. For me, I would rather prefer an open surgery with all the expense and nothing solved. But as a surgeon, it might have its own advantage.
Okay. Now, one final question.
Yeah.
Now, I want to know the kind of mentoring, as you're a theatre practitioner, the kind of mentoring nursing faculty get before going to the theatre. Whether there is any mentoring followed there.
I mean, I don't know, are you talking about your tutors coming into theatres?
No, staff nurses, before they go to the theatre, what is the procedure? What kind of a mentoring is given to them?
Absolutely. Ma'am, you see, I don't know, even though I keep telling I'm a theatre practitioner, I was only theatre practitioner for till 2014. Then I become a band 7. I'm a theatre matron now. So what we got here is we got nearly 353 staffs. We got nearly 24 theatres. We got 353 nurses / ODPs. They're called theatre technicians. And what we got something called competency book here. And we always give them a mentor. Again, every student, every nurse's thing, everyone's learning curve is different. Normally, a person takes 3 to 6 months to achieve his competency. Again, theatre nursing is totally different from ward nursing. It is totally different. You put me in a ward, I cannot do a single thing. And my knowledge is fully of theatre. And theatre is a different kind of specialty. It's like a trade. And it's like a trade. It's like a plumbing. It's like like a carpentry. The more we do these things, the more we get expert in these things. And the only thing which I will say, if you got still students watching this seminar, if your aim is to become a theatre practitioner, you will enjoy it, because for those nurses who thinks I'm not going to be talking to a patient, I don't want to be cleaning a patient, because I'll be very honest. When I finished my 4th year of nursing, being a male, I came out and I thought, am I going to be cleaning a patient? Am I going to be doing a bed bath and other things? So yes, that is a part of your nursing. You can't deny that. Theatre is a bigger scope of practice. And if you coming into theatre, is more technology. We are more technology than an engineer would have seen in his life. We have more experience than a surgeon would have seen technology. We would have come across so many technology in our life. So for those people who are especially looking for a career, I'll be very honest, when people listening to this, many people enter into nursing thinking, I will go abroad, I will go easy job and other things all. But then in the first year, when they do nursing practice and other things all, they'll actually absolutely down. For those people who think, am I going to be coming in? There are so much of scope of practice. Theater, then you can, I don't know, it's in India as well. Then you do your theater nursing, then you do surgical first assistant, means like you will be working with a surgeon, helping him to position and do things. You'll be working along. There is something called SCPs, which is called surgical care practitioner. I'm sure the scope is now in India as well. So you will be working in a same operating complex in a different room. You will have your own patient. You will be like a surgeon. So you will do procedures like straightforward diagnostic procedures. Like example, if you're in orthopedics, you'll do arthroscopies, straightforward wire fixations, plastering, those kind of things as an SCPs. If you're working on a general surgery, you will do endoscopy, gastroscopes in and out, taking specimens. If you are on urology, you do cystoscopy. So there are scope of practice is so much. You have to work your way up. So those people who are thinking, I finished my BSc nursing. Oh, I don't want to go do my MSc nursing because teaching is not my passion. I want to develop. Then there is a lot of opportunities. Either in I can comment on UK definitely, but I bet you got lots of option in India as well. It's just that you have to keep working on it. The more we do these things, the thing. And only one thing, you see, they say the Yosikana, Veda, I mean, when I did my BSc, yes, I was a bit outstream. But one thing which I can see nowadays with children is they get too much occupied with mobiles and thing. So what they need to do is they need to, they need to have fun. But college particularly, we have to have fun. We can't deny them from having fun. But how much time you're spending on things, make sure that every day you go home and do your homework. And nowadays the technology is so brilliant that you don't need someone to teach these things. The materials are already in internet. When I go and do a case which is different from another case, so if I'm scrubbing for a hip replacement, the day before I'll do my homework. I sit in the computer, I'll look into YouTubes, and because you don't want to be a joker in the theater, so if this knowledge, I'm doing it now, but I would expect my students to be doing it when they are in the student thing itself. 4 years when you're studying, yes, please do have fun. But how much time you're having fun, just make sure you spend a quality time in your studies as well. And there is so much in internet, you can access everything. Because now it is all very competitive. This is what I said when I was in your college as well. Now the field is so competitive that you decide what you want to do in your career. When you pass out from a nursing college, you get into a government job, then slowly you work your way up to nursing super, and that is not happening anymore. Nowadays, you have to do your appraisals, you have to develop your CPDs. There should be a continual. So you start working from now as a student, then you get the habit. Otherwise, you will be very hard to develop in your career. Next time, ma'am, if you tell me a topic and then if you tell me the objectives, what portions I need to cover, then because yes, Ganeshan said look into the INC website. INC was like pretty much like surgical management, but I would rather you tell me much more micro objectives, then we can nail those objectives and we can come back with the thing.
Thanks a lot, Sam.
Thank you.
Because I really want my students to get this expertise.
No worries,
I think students will feel proud of Mr. Sam, and by now many would have developed a thought that they should become a theatre practitioner. So it's even difficult than an ICU practitioner, right? So
yeah,
I mean, many would have got this idea.
Absolutely. ITU is totally different, ma'am. ITU is totally different. ITU is because you do the same thing to the same patient. And the problem with me, I've got a little attention span. So you need to keep me different things to occupy. And for those kind of people, I think theatre is the best career. Anything
Thank you very
more?
much. Students, now if you are ready with your doubts, you please ask.
Is there any difference in prognosis from robotic to manual performance of surgery? Outcome basis?
Outcome is definitely better on robotics. As we said, it's less scar. So obviously your length of stay in the hospital is so less. Your healing is much more better than the previous times. And you see, again, when you talk about prognosis, you have to factor hospital stay. The more we stay in a hospital, there's a more chances of you getting hospital-induced infection as well. So MRSA, or now it is corona everywhere. So it is how we do these things, the faster the recovery. Most of the robotics are under called enhanced recovery scheme. Means like at the end of the day, they even go home. Because a scar is only this little scars, you don't need any specific attention on it. But in terms, as I said, there is always a little disadvantage on laparoscopic or robotic surgery is, obviously you're not seeing what is at the back. It is not same as, example, I'll tell you, when you use a chopstick to eat noodles, how much of difficulties we have. The same thing is the problem. Prognosis wise, robotic got good prognosis than open surgery, purely because of the incision site and other things. Yeah.
Thank you,
Sir, good morning, sir. I have
Hello.
a doubt, sir.
Yeah, tell me, please.
Sir, my friend was working in Dubai, sir.
Mm.
So he was telling about a procedure. Actually, I forgot that name. So they used to tie the cuff at the lower limb till hip, from leg to hip, and they give the pressure.
Yeah.
So that the blocks in the heart gets relieved through increasing the peripheral resistance. The block in the heart gets received, and there that procedure was very particular, famous. They don't go for CABG. The sheikhs who are in Dubai, the persons who are in Dubai, that I forget the procedure name.
I honestly don't know. I never heard about a tourniquet applied, and I think, we do tourniquets in a massive cordlets, like, if you have a polytrauma and if it's bleeding everywhere, what we call is, like, we got pelvic binder tourniquets, which is basically like putting a big tourniquet on the abdomen and tightening it. By tightening it, you don't stop bleeding. But I don't know about the technique you said, honestly. And as I said,
I heard that from the leg till abdomen it will be tied up, and gradually some resistance, some pressure has been given. So new veins has been, so that will remove the blocks in the heart. So it was a 3 months once they used to follow this technique, and the 75% of blockage is getting cured. I forgot the procedure. If I can, I will just share with you.
Yeah, please. And as I said, I'm more happy to research on it. You see, again, it depends what kind of hospitals we are talking. Our hospital is a surgical hospital. There are hospitals which are...
It's a specialized hospital for this purpose only.
Perfect,
only
perfect.
For 75% block is there. They are doing the procedure and they are getting cured of. He told me, but I am unfortunate of that procedure name. I will get back to you, sir, after knowing
No
that.
problem, no problem. You see, as I said, the thing is, like, if you work on a district hospital, first line of treatment for any myocardial infection is angioplasty or stenting. And
yes,
in my hospital, we are very surgical hospital. So we have 24 theaters. So we are very focused on surgery. So we might not do other therapies. This is what I want to tell you. We don't do other therapies. And currently I'm quite out of touch as well. So let me know. I'm more happy to investigate on that.
Okay, sir. Thank you.
Thank you.
Any other queries, participants?
Yes, ma'am.
Yes.
Hello.
Hello.
Yes. Yeah,
yes.
Good morning, sir.
Hello, Selva.
Sir, what is meant by revascularization and its complications?
No, revascular. See, earlier we had blood vessels supplying blood to the heart. It is called vascularization. And because of the atherosclerotic patches, the blood has been stopped. What we are doing is we are replumbing again. It is called revascularization, means we are opening the vessels back again. So imagine if your atherosclerotic patch is a bit soft at the early stage, we can put a balloon plastic, we can dilate the vessel. That is one option. If the balloon is not working, we can put a stent. A stent is like a stent. If you see your in the pen spring pens. If you have a pen, if you open it, there is a spring inside. Yeah. A stent is similar like that. So in a vessel, a spring will go and sit, making sure the vessel is patent. You know, when I say patent, means the vessel is open. So all these things fails and the atherosclerotic patch is too thick. We cannot do these techniques. Obviously, we have to get another vessel and the bypass from. So imagine when a road is shut. When you're going from A to B, when a road is shut, what we do a bypass. So, and the coronary vessels are being completely blocked. What we do is we take a fresh vessel from leg or even hand, go to the proximal part of the arch of aorta where the arch of aorta starts, make a little hole. First plumbing starts there, then take the end of the vessel, go to the heart. So it might be the anterior of the heart, or it might be the posterior aspect of the heart, or lateral dorsal. Wherever there's no blood, you patch it there, you stitch it up. Then you're giving blood. It's like, that is called revascularization. Means you're you're opening the vessels again.
Okay,
So
sir, again, can you tell me the complications?
Oh, the complication is again, you're using the same blood vessel. So imagine, Samuel, for me, you take a blood vessel. I don't have a good health habits, like I drink, I smoke a lot. How my vessels have been blocked using an atherosclerosis. After 10 years, what will happen if Samuel doesn't change his practice? The same vessel will go into atherosclerotic again. Do you understand?
Yes, sir.
So understand when I say you have an old car, yeah? You have a old car. I am not buying a brand new engine and fitting into the car. I am taking another part of an engine which is old and rusty and using it on the same thing. So there is an element of, after 5 years or 10 years, you love it. I'll tell you a good example. My father had a CABG, but he never changed his habits. He was still smoking and drinking. So his life after a CABG was only 3 years. He had an operation in 2015. He died in 2017. I know there was another patient who we treated, lived for 20 years because they changed their habit. After that, they had a very good living habit. They did exercise. The food was under control. They took the drugs properly. The life on these vessels are 20 years. The doctor only can give you guarantee for 20 years. Either 20 years you die, Selva, or you need to come for a re-CABG. These are the complications.
Sir, and one more question.
Yeah.
If the patient is had surgery CABG, and after that most of the complication is there. Hello?
You're audible, Silva.
Selva, the only thing which I can tell about these cases are, I can only talk on surgical aspect. Again, you see, you can ask me a question, after having a CABG, will the patient have a myocardial infarction? Yes, he might have. Reason is because heart has been supplied by numerous of blood vessels, like left, anterior, descending, circumflex, lot of. So if one part, we have corrected everything, but after going forward in the next year, there might be a problem on another part of the artery. The patient won't be fit enough for another surgery. You can't just keep on opening the sternum, taking the heart again. You can't do that. So there will be obviously complications. You know, that is where when you are hitting 40-year-old, you need to change your whole life practice. You need to be getting into a good, healthy eating habit, good exercise, good way of your life. Otherwise, for Indians, especially Southeast Asians, heart disease is inevitable unless we change our living style. I'm sorry to say that, but I've seen my father himself dying in cardiac arrest.
Okay, sir.
Yeah.
Thank you. That's
Thank
all.
Any other doubts? I think we are taking more time. Sam is also very busy. He
Yeah,
gave
I've got
till
work.
11:30. Any other doubts, or shall we wind up the session? Okay, Sam.
Thank you, ma'am.
Thank you on behalf of Indrani College of Nursing. I really have no words to thank you. Anyway, at the final conclusion, I hand over this to our IQAC coordinator, Dr. Rajeshwari, to propose a formal vote of thanks.
Thank you.
Thank you, ma'am. Happy morning to all. On behalf of IQAC and Department of Medical Surgical Nursing, Indrani College of Nursing, would like to extend my gratitude to Almighty first for showered His blessing. I'd like to thank our respected principal, Dr. Mallika Kannan ma'am, for constantly supporting us in organizing all the event, who is our backbone for our success. I am very glad to extend my warm gratitude to Mr. Samuel Nanamani, theatre practitioner from Broomfield Hospital, UK. So we had a good experience with you when you came in person, dealt about robotic surgery. So when we had a thought of celebrating our cardiac world heart day, so Professor Ganesan proposed, volunteered your name. So we again dived into a surgical aspect today. From the basic, and you explained well about the types and each advantages and disadvantages and limitations with robotic and manual surgeries. So our students gained much knowledge in detail about the surgical aspect of cardiac surgeries, I think, sir. So your deliberation is very excellent. You had a very patient in clarifying our doubts and all. Thank you very much, sir, for sparing your valuable time with us today. I thank Professor Ganesan for taking initiative and referring such a eminent people to us. And I extend my thank to Ms. Kokilavani, Organizing Secretary, Department of Medical Surgical Nursing, for smooth organization and smooth for successful completion of today's webinar. Thank you. Thank you, Vani.
Thank you, ma'am.
I thank our faculties and the faculties from the outside and our students and alumni. Few of our alumni also joined today, I think. I thank each and everyone for their curiosity in acquiring knowledge and taking effort in updating, keeping update about the newer technologies in cardiac surgeries. I hope everyone enjoyed the today's session. I think we gained much knowledge and we refreshed ourselves about the cardiac surgery. This is a new experience for us because we don't get much experience in theater and all. As a part of our curriculum, we just go and come back. So this is the newer experience even for us. Thank you very much, sir, for your expert deliberation. Thank you, one and all.
Thank you. Thanks for listening as well. Hope I didn't bore you too much.
No, we didn't had such feels, sir. We are listening for 2.5 hours, but we don't find we are sitting for such a long period. So you two very interestingly explaining all the concepts. No, it's very new to us. That's creating interest among us. I hope on behalf of our participants, I am giving this comment. I think any.
Thank you, ma'am.
Yes, sir. Very excellent session, sir. We, as ma'am said, will be in continue contact with you for future sessions, sir. Thank you very much.
I'll send my email address if students got some doubts. Let them pin it an email. I'm more happy to give it. Perfect. Thank you.
Thank you very much.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you, ma'am.
Thank you, sir.
Thank you, sir. Participant can submit your feedback.
Thank you, sir.
Thank you. Thank you. Thank you.
Thank you, sir.
Thank you. Thank you.
Shall we wind up?
Yes.
Yes, ma'am.
Participant, kindly submit your feedback form for your e-certificate generation. Thank you very much.
Yes, ma'am. Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am.
Thank you, ma'am.